I've been looking after sickle hips for over a decade now, and it's a great privilege to be part of the multidisciplinary sickle cell team at our trust. I'm going to talk to you about the avascular necrosis in all its forms and all its locations, and then I'm going to spend the second half of the talk really outlining our experiences with total hip replacement, and really to tell you that it's a really good news story. And following on, I'm going to be evangelical about telling you that how great total hip replacements are in sickle cell patients these days if you do them in the right place with the right experience and facilities. As we all know, avascular necrosis is a very common complication of sickle cell disease. It's disproportionately common in HBSC. I don't really need to tell you that. I don't really need to tell you where the affected sites are, but clinically the most important sites that are affected are the head of the femur, i.e. in the hip, and in the head of the humerus, otherwise known as the shoulder. Clearly it can affect the vertebral body, the ankle, the body of the talus, and around the knee. But really, in terms of patients with pain from sickle cell disease that can be helped by orthopedic surgery, it's really the hip and, to a much lesser extent, the shoulder. I think of infarction of the bone affecting the femoral head as there are two sort of patterns of disease, really. There's a sort of classical avascular necrosis that affects a segment of the femoral head or a segment of the humeral head. And it's the kind of avascular necrosis that alcoholics get or patients on steroids get. It's kind of bog standard avascular necrosis. It affects a large part of the femoral head and it's got a very poor prognosis. In addition, you also get changes in the femoral humeral heads in sickle cell disease of multiple small infarcts. So you get a sort of these little spots of avascular necrosis within the bone, little spots of dead bone, even though the structure of the bone is essentially intact. And I'll show you pictures of those. The sort of disease process, as we all know, is obstruction to the microcirculation of the femoral head. And in sickle cell disease, that's predominantly due to sickling of the cells. Tell you to suck eggs. But I think I want to really concentrate on what happens then. Because actually what happens is if the blood supply to the bone is obstructed, you get death to the osteocytes. So the bone itself dies. Now, there are two consequences of that. Firstly, the structural integrity of the bone is lost. So it goes from being nice, firm, good bone to squashy, soft bone. And if there's continuing load through that bone whilst it's squashy and soft, it will collapse. But another key additional factor is there's loss of integrity between the overlying cartilage and the underlying bone. So even though the bone may remain structurally intact in milder cases, you've still lost that adhesion between the articular cartilage and the underlying bone. And that is also painful, and that can also lead to bad things. And that's I suppose the key thing I need to explain to you. There's far too much emphasis on the bone and maybe not enough emphasis on the interaction between the overlying cartilage and the underlying bone. And you can see this actually on this. It's probably easier. Are you seeing that on? Oh, good. Yeah, I can use the arrow because that's kind of easier. But this is someone with early avascular necrosis. Here is the segment of dead bone. It doesn't look particularly dramatic. The articular surface looks all very nice. There's the articular cartilage. But here, can you see this gap here? It's clear on the right, and that is the separation of the articular cartilage from the underlying bone. Now, there's a lot of staging of avascular necrosis. The one that I really have a very simple staging, which is the head collapsed or is it not collapsed? And I think that's what I really would like to concentrate on rather than these complicated classification systems. So I'll just show you the classical MRI appearances of avascular necrosis. It's called this sort of, there's a double density separation, this sort of geographical separation between the dead bone here and the living bone there, and then this sort of zone of edema in between. And you see this sort of double line of separation. So that's classic segmental avascular necrosis. And then this is this pattern of multiple small infarcts. Can you see what I mean? There's this sort of You know, the normal bone is on these sequences. Who hope there are no radiologists in the audience. Is the dark stuff, and then the dead stuff is the white stuff. I think on this, and you can see it's affecting the acetabulum as well. So this can be painful as well because there's quite a large volume of dead bone in there, and dead bone is painful. So if we just go through the sort of the simple classification and the most effective and clinically relevant classification of avascular necrosis, we talk about the disease being pre-collapse or collapsed. And I really want you to focus in on that rather than 27 stages of the ARCO classification and its 19 names that come with it. So here is our segment of dead bone here. And it's even though it's dead, the bone still has its structural integrity. There may be loss of the adhesion between the articular cartilage and the underlying bone, but this will essentially look almost normal on an X-ray. And this is the collapse. So we've lost the structural integrity of the bone, and the thing has dropped down. So I think that's, and I'll now show you what these look like in real life. So the pre-collapse stages, according to ARCO, are stages 0 to 2. And this is classic stage 1 disease, really, in that essentially the X-rays are normal, maybe just with the eye of faith a little bit of sclerosis, but basically the X-rays are normal, but the MRI clearly shows a little segment of avascular necrosis. And again, this is just, again, you're just starting to see a little bit of sclerosis here, but essentially the ball is round and essentially they're normal. So the post-collapse, basically stage 3 and beyond, really. And I think when you're starting to lose the integrity of the femoral head, not only have you lost its normal spherical shape, but if you've got collapse, you've inevitably got separation of the articular cartilage from the underlying bone, and you get this kind of wrinkled appearance. And that, as I say, is painful. So now this... I want you to concentrate actually on the right hip here. I make no apologies for showing you X-rays. I think you should really get involved and really look at your patient's X-rays and not just... I mean, the quality of radiology reporting is so variable, and you know, you may find that the report is from an SPR in radiology who last week was an SHO in general medicine. I mean, you know, you've really got to just get engaged in these, and I'll hopefully help you with that process. But here we have a sort of a segment of classical avascular necrosis. Now, probably superficially, it probably looks like that isn't collapsed, but if you look more closely, it actually is collapsed. And if you follow the line here of the ball of the femoral head, well, you can see it has a little step there. Can you see that little step just there? And actually, this, you know, when you've got this amount of femoral head involved, it must be collapsed because you've lost a whole load of bone around here, and the thing's just gone. You can also see that on the lateral X-ray as the crescent sign, and the crescent sign is superimposition. The lower line there, the crescent, that lower line just there, is actually the outline of the collapsed femoral head. So you're looking at the collapsed bit, and that's the normal contour of the femoral head. So it's gone from that to that, and that's what you're looking at from the side view, and that's what the crescent sign is. So even this has collapsed. However, I don't think you will have any difficulty identifying that as having collapsed. Yeah? So please do not take an MRI of this hip if this is presenting to you in the clinic. You're welcome to scan the other hip if you're looking for asymptomatic disease or silent disease. Don't have a problem with that. But please don't waste money by scanning that hip, please. So how common is avascular necrosis in our sickle cell patients? Well, it's really very common, and perhaps the best study, possibly the only study really looking at the prevalence, comes from a very famous French hospital, Créteil, which is the Croydon of Paris, isn't it? Has anyone been to Créteil? It's actually it's in the southeast, isn't it, of Paris? But they have a big sickle cell population down there, and they did this epidemiological study, looked at 200 patients, and they seem to relentlessly X-ray them down there. I don't know quite how they have the resources for that. I suppose it's the kind of thing we used to do in the NHS, isn't it? Do a lot of things like that, but we don't anymore. What they saw was when they took the first X-ray, only a quarter of the hips were normal, and the other 75% actually already had radiological stages. And what's concerning, this is the thick atenarlate stage, already half of them had collapsed disease. I don't think that's quite what we see in South London, I have to say. I don't think it's quite as bad. But if the femoral head is affected, almost always the humeral head is affected as well, and seldom elsewhere. But I think these are quite sort of enthusiastic and over-inclusive reports. But it still makes the point that avascular necrosis is very common. This is avascular necrosis in a shoulder. You can see the sclerosis, but again, this hasn't collapsed. And then what they also looked at was the incidence of surgery for avascular necrosis. And most of the time they were doing surgery for the hips in that time. So during the course of the follow-up, 40% of their avascular necrosis patients had some kind of surgery to their hips, which is a lot. So what happens to avascular necrosis? What's the natural history of it? Well, unfortunately, it's poor. And again, from the same centre, they looked at 92 symptomatic hips in 64 adults, a follow-up of 17 years. This is the presentation, very similar to what we saw in the last stage. But unfortunately, a lot of them progressed. So 75 hips without collapse, 65 of those had collapsed within 5 years. So that's a kind of a bad news story. Now, whether that's any different now because we have much better treatment of sickle cell disease, whether disease-modifying agents, hydroxyurea, actually, and the general better care of the patients is affecting this, we don't know. And I suppose it would be right to do this kind of thing again, although quite how one would do it, I don't know. But, you know, it's bad. You know, if you've got avascular necrosis of your hips and sickle cell disease, unfortunately, you'll get to meet me eventually, which is you know, maybe not ideal. I don't know. I'm quite jolly though. You know, get them through the surgery usually, don't we? Dr. Howard and I, with double-pronged assault. How does avascular necrosis of the hips present, or avascular necrosis in general? Night pain is a real feature. It's disproportionate at night. And, you know, patients may be able to get around during the day okay, you know, a few painkillers, but it's the night that sort of bothers them. And hip pain is felt in the groin. I'm going to move. There's a camera following me. But it's kind of here. And patients may localize the pain using the thumb and index finger like this, which we call the C sign, or they may use 2 fingers to point at the hip like that, but it's there, and it can radiate the buttock, upper lateral thigh, down to the knee, even to the ankle. You know, the hip pain can spread down there, but that is where hip pain is. This kind of pain is usually coming from the back, from sickle spondyloarthropathy, and again will be less prevalent at night. Range of motion in the early stages is not affected at all, really, but you may notice a subtle restriction. Certainly the patient will report that they're struggling with life, they can't get around, struggling to get to work, struggling to look after the kids, they're limping, they're taking more analgesics, and just things are difficult for them. And then sort of in the later stages, when you have collapse, you'll have leg length discrepancy, constant pain, you know, and lives completely blighted, and we're all familiar with patients with end-stage hip disease and sickle cell. The other features that may be associated, as I mentioned, HBSC, is obviously it's avascular necrosis disproportionately common in HBSC. The associated avascular necrosis is the humeral head, as we mentioned, leg ulcers, unfortunately, high hemoglobin values in SS patients, and as I implied earlier, early disease may be asymptomatic. So the indication for MRI sometimes can be in the asymptomatic other hip rather than in the hideously deformed, stiff arthritic hip that you can see on an X-ray. So how do we investigate this? Well, please get some X-rays and please look at them yourself so that you can see whether there's collapse or not. And that may be all you need to do. So you spend 50 quid rather than 600 quid. So why do we do MRIs? Well, I think you do MRIs if you don't know what's wrong with the patient, basically. If they're getting hip pain and the X-rays look normal, you should get an MRI. So as I say, I'm interested in looking for asymptomatic disease in the other hip, because if you're going to do a hip replacement on one side, it's actually pretty easy to drill the other side under the same anaesthetic, and that's actually quite a good thing to do. If you've got uncollapsed disease, it's important to see what the extent of the disease is. Now, if it's just a small amount of femoral head involvement, you may want to drill it. But if it's a large amount of femoral head involvement, you're not going to bother with that because you know it's going to go bad. But please do not scan patients with deformed femoral heads. So if you've got a patient coming in sort of like this, okay, with sticks and, who've been struggling on, just get an X-ray. That'll be all you need, because clearly that patient's hips are both terrible, and that will all be obvious on the X-ray. So what do we do with early disease? If you've got an uncollapsed femoral head and it's the avascular necrosis is involving an arbitrary percentage of the femoral head, then I will do a core decompression. Now, what is that arbitrary percentage? The older you get, the lower that percentage goes. I can make a little algorithm now, couldn't I? It's 100 minus the patient's age or something. I can come up with something. But basically, on the teenagers and the guys and girls in their 20s, you're going to have a go at drilling more than in someone who's in their 40s and 50s, because they're worth a shot. They're younger patients. You may get lucky. It doesn't work very well in sickle cell patients, and really it has to be less than 20% as my arbitrary sort of, if you're going to quote me on something, 20%. So that little lesion that I showed you earlier on one of the MRIs. There's very little written about core decompression, and it's interesting that this series, which is really old, but it really concentrates on younger patients, so patients between 9 and 21. And basically, if you do it for early disease, they do well. If you do it for late disease, funnily enough, they don't do well. So I still do it. We do about 3 or 4 a year. We don't do many. Maybe that's it. Maybe 2 or 3 a year, or 2 or 3 patients. The other thing, this is the kind of study, when it first came out, I was horrified and thought it was terrible, because I was a big believer in core decompression. But actually, I think it's a very good study, because it's now confirming my prejudices rather than disagreeing with them. But this was actually quite a good trial, comparing the effect of core decompression and physiotherapy in avascular necrosis. And it really, at 3 years, there wasn't any difference between the two groups, which I think for early disease, I think the role of core decompression is, it's undefined really. It's a funny operation. All you do is under image intensifier, you put the patient to sleep, you drill up the femoral head, and that magically reduces the pressure within the femoral head and may stimulate healing. It's a mysterious operation, but it occasionally works. And because it's pretty atraumatic and, it's a tiny incision and stuff, it's a sort of a do no harm operation. Although we have recently had to look after a patient who got an infection after core decompression from elsewhere, which is a very challenging case to deal with. So it's not entirely benign. So anyway, look, let's get into the enthusiasm that I've been given the remit from the chairman. I've got to get out there. Is how do you treat these collapsed femoral heads? How do you deal with these patients with very severe pain and stiffness in their hip? Well, you do a total hip replacement. And I put there realignment surgery in children. Again, we're increasingly doing total hip replacements in teenagers and children as well, because, that's sometimes all you can do, really. We know that traditionally the results of total hip replacement are very poor, and this is the kind of thing that possibly your orthopaedic colleagues in other hospitals would have been brought up with. This was certainly the environment I was brought up with. There's a particular paper from the Central Middlesex that had a huge negative influence on doing hip replacements in sickle cell patients. But again, in the 90s we had sicker patients. There was no comprehensive care, no hydroxyurea. Patients were not prepared very well, maybe not enough antibiotics, use of cemented cups, cemented acetabular components for the hip replacements. And of course, the cases were difficult. They're difficult hip replacements to do from a technical point of view. Not only are they difficult sort of physiologically and pathologically, but actually to physically do the hip replacement is also harder than usual. And the orthopedic technology was not available at that point. And so this was a fairly sort of traditional situation really, where you've had a patient who's had a hip replacement that's got infected. The hip replacement has then been removed, and this is what the patient's left with, which is a short, stiff hip. And, it's not a great hip if you don't actually have a hip. It's okay. It's not as bad as maybe you'd think, but it's not good. So anyway, what do we do? Well, I'm going to tell you. You do this surgery in tertiary centres as part of a comprehensive sickle cell service, and then you can get really good, reproducible, predictable results. And this is our comprehensive sickle cell service at Guy's and St Thomas's, which I'm sure you know all about. Perioperative management. So what Dr. Howard does is she transfuses the patients to get the HbS percentage. She actually takes down to less than 30%, do not, Dr. Howard, but that's just, it should be less than 50%. The ulcers need to be healed, and you need an anaesthetist who's got a bit of courage. They're hydrated, they're given lots of oxygen, we warm them. Spinal or epidural anaesthetic is absolutely vital. We use the cell saver, and I'm very happy for people to throw rocks at me for using that, but actually it's kind of okay. If we've got all this lovely transfused low HbS percentage blood, then why not suck it up and return it to the patients? They do bleed more than standard hip replacement patients, and of course you may need a bit of allogeneic blood. We poison them with antibiotics for 36 hours. I'm a simple chap. Teicoplanin is for gram-positives, ceftazidime for gram-negatives, and it saves doing levels and with vancomycin, gentamicin, renal diseases, all that kind of stuff. So keep it quite simple. Use very expensive antibiotics, but for a relatively short time. Now, I'm absolutely passionate about the use of uncemented implants for sickle cell disease, and I think in certain cases you can get away with cemented stems, but you cannot use cemented cups. You absolutely cannot do that, and it's very clear on that. Cemented cups, they just don't work. They fall out and they wear out, so why use them? The results are poor, and the only not awful published results of total hip replacement are with uncemented components, and we're about to have some brilliant published results of total hip replacement because we're just finishing off our own series for publication. But this is a cemented total hip replacement here. Have cables around the femur here. It's not to sort of and just sort of look at the architecture of this. Can you see a hole to put the stem? You can't really see a hole there, can you? Can you see to try and get something down there is actually quite challenging. And you need a drill to get down there, and this hasn't really happened with this cemented cup. So I've done an uncemented hip on the other side, and it kind of, I don't know, maybe looks a bit better. I've lengthened his leg a bit. But the real, I suppose, one of the issues with this cemented stem is that the surgeon doing this really had absolutely no idea what he or she was doing. I don't know who actually did it. But clearly, to put the stem out like that and trying to use that kind of implant on a femur like that shows a fundamental lack of understanding of this condition and even of hip replacement. So there we go. I put it out there. So what you need is you need a stem that's basically cylindrical rather than wedge-shaped, so that you can deal with this very tough bone. It's like trying to put a stem down the inside of a broom handle. The bone is very difficult to work with. You need special stuff. You need little burrs and drills, and you need to be familiar with using the image intensifier to do a total hip replacement. You need small implants and big implants. You need a system that gives you all the different sizes. The bone is liable to fracture. It's brittle, and it's liable to bleed. So the cups are usually easy to do. It's getting into the hip and putting the cup in, that's kind of quite easy. It's the femur, and what Dr. Aziz asked me, he says, what's the femur like on this case? I've now trained him to actually look at the x-ray now so that he can actually understand. So to see that if you're going to have a difficult femur, then he'll be able to see that. And a difficult femur looks like this because there isn't anywhere to put the implant down the inside. Yeah, it's absolutely occluded. You may think something like this on the left-hand side, you may think there's possibly something. So if you get to this far, if you get to there, then somehow it'll be okay. It isn't, I can assure you. This is like putting an implant down into a solid cylinder of bone. And you need patience, experience, and equipment to deal with those. And that's the kind of thing you do. So narrow stem, drilled it out, and there's the thing. But I'll just throw this slide in really just to show that the bone is brittle and difficult to work with, and sometimes you do get little cracks just as you're putting the implant in, and these cables are in just to support a little crack. It's of no consequence, but it just to sort of make the point, really. So these are sort of our experience of primary hip replacements over our first 10 years. 62 primary hip replacements, 44 unilateral, 9 bilateral staged. mostly women, actually, interestingly. Mean age of 35 years, range of 17 to 54, and not always was the diagnosis avascular necrosis. We had one patient with hip dysplasia and secondary osteoarthritis, one post-traumatic osteoarthritis after an acetabular fracture, one hip fracture in a lady with a previously spontaneously fused hip from avascular necrosis, and another arthrodesis conversion. So it's not always avascular necrosis. And what we've used ceramic on ceramic bearings in almost all. We use 2 large diameter metal metals for specific instability issues in 2. SROM stems, which is that stem I've shown you in the majority. We've really abandoned these other stems now. That was very early on in the series. And basically, the key thing is that there have been really no signs of wear or loosening on any of these patients. We've had a single dislocation, and we've had one deep infection in a very complicated case from Nigeria, but which we've fixed it. But she did have a post-operative infection. We also have done some revision hip replacements from none of our own, I hasten to add, and they seem to be doing pretty well as well, although they're pretty challenging cases, but they do pretty well. So essentially, if you want to do successful total hip replacement in sickle cell disease, if you come from South London, then you need to send them to us. But for everyone else who wants to get involved in this around the country and around the world, you need a multidisciplinary team. You need to look after the patients properly, get them ready properly, and you need orthopedic surgeons who are skilled in total hip replacement and patient in doing total hip replacement because they are challenging technically to do. Final slide is just treatment of avascular necrosis elsewhere. In the combined sickle service, it's the only general orthopedics I do really, because most of the time I'm just doing young adult hip surgery. So actually, it's kind of quite interesting. Occasionally, people coming in with acromioclavicular joint arthritis or a torn meniscus or something, and they just happen to have sickle cell disease. So I do sort of screen the patients out for my colleagues, because clearly, if anyone needs an operation on their shoulder or their knee, I have colleagues to do that and refer them on. But really, the only other area that regularly gets an operation for avascular necrosis is in the shoulder and the shoulder hemiarthroplasty. There's we do a few of those, maybe 1 or 2 a year. I mean, yeah, maybe compared with maybe 10 or 12 hip replacements. So it's very much small print, but because the shoulder is not a weight-bearing joint, the bone can heal without collapse, and that's the key difference between the shoulder and the hip, whereas the hip will almost always collapse because it's a weight-bearing joint. The knee, I mean, quite often you see avascular changes in the knee, but usually it's not, the avascular segment is deeper in the bone than the joint. It's not involving the joint. So the joint itself is relatively okay. So once you manage the acutely painful episode, it tends to all just go away because you don't get the collapse. I mean, conceivably, if you've got avascular necrosis of the talus, you could have a fusion of your ankle. I've never seen it or referred to anyone for it. And likewise, spinal fusion, there could be a place for it, but I've never seen it or referred it on. So really, it's in terms of orthopedic surgery, you need a hip surgeon and a shoulder surgeon. So thank you very much indeed.